In essence, specificity is the ability of a test to identify individuals who do not have the condition of interest. Or in other words, if the test has high specificity, then a person without the condition will most likely test negative, and those cases are considered true negatives. However, sometimes patients who do not have the condition still test positive, and that is called a false positive. Unfortunately, that happens because no test has perfect specificity. But the higher the proportion of true negatives, then the higher the specificity of the test. And conversely, the higher the proportion of false positives, then the lower the specificity. If a test is being used to make a definitive diagnosis, then it is most likely associated with a low proportion of false positives. That is, a test with high specificity mostly tells patients without the condition that they do not have it. It is a low false positive rate that makes highly specific tests useful for diagnostic purposes. And that makes sense because you would not want a diagnostic test to incorrectly tell patients that they have the condition when in fact they do not. A middle-aged woman presents to the emergency department with an acute onset of dyspnea occurring one day following an overnight flight. Her only other complaint is a painful and swollen right thigh. With appropriate therapy underway, initial studies returned non-conclusive. D-dimers are elevated and the plain chest x-ray is normal. A pulmonary angiography is ordered to confirm the diagnosis of a pulmonary embolism. This rather basic vignette shows the ability of a very specific test to help to confirm a diagnosis. Another example would be the double-stranded DNA antibody test for diagnosing systemic lupus erythematosus. However, it must be noted that if the prevalence of the condition is low and the specificity of the test is not sufficiently high, then the test may produce more false positives than true positives. That is, most patients with a positive test would not actually have the condition. This issue will be discussed more thoroughly in another lecture. While specific tests can reliably identify individuals without a condition, they are not necessarily good at identifying individuals with the condition. Now, it is true that with a highly specific test, a positive result means the condition is very likely. However, the problem is that specific tests aren't necessarily good at detecting the condition. For some individuals, the test might say they don't have the condition even though they do. That would be called a false negative. So although highly specific tests can confirm a diagnosis, they may not be able to rule one out. Let us imagine that the red rectangles in this figure represent individuals with the condition of interest, while the white rectangles represent individuals without it. The yellow line is the cutoff point above which a test returns positive. Currently, there are several white boxes above the yellow line. Those white boxes represent false positives, meaning that at this cutoff point, the test lacks specificity. As the threshold for a positive test is moved further away from the norm, then the number of false positives decrease. This makes the specificity of the test very high. However, now there are red boxes below the line, representing false negatives. That is the trade-off that occurs when increasing specificity by moving the cutoff point of the test away from the normal range. A teenage boy is sent to a pediatric neurologist because his doctor suspects that he may be experiencing seizures. The boy's development has thus far been normal, and he does not have any particular issues that he would like to talk about. After a short discussion, the neurologist suspects the possibility of juvenile myoclonic epilepsy and obtains consent for an electroencephalographic study. No abnormalities are detected. This is an example of a false negative. While EEG can be very informative, people with epilepsy very often have completely normal readings in between seizures. Other tests that commonly produce false negatives include the anti-double-stranded DNA test for systemic lupus erythematosus and an X-ray of the lumbar spine when looking for sacroiliitis.